That's great. Good afternoon, everyone. Those of you watching online as well, welcome to this session. The brief given to us for the next 1 hour is challenges in delivering healthcare in the Indian context. And because there are so many vistas to that, there are so many views to that, and so many problems which are there, we've got a very varied panel. So don't get worried when you see so many people on the panel. We'll keep it tight, as Dr. Ashley was suggesting, rather than keeping it loose, as he said. Okay, so he was my teacher from my UG days, so there's a little deference which you will see. Okay, so the format we're going to go in is I'm going to go to each of them and try and get one problem talked about, and not just point the problem. They also have to give us at least a direction in which we can find a solution. We won't get ready-made solutions, but at least a direction. And I think that will help each of us, both the panelists and those of us who are listening. Then we'll keep moving down the line, back and forth, and then we'll go back to them with specific troubles. And the last 20 minutes, I want to keep it open for people in the audience to put up your hand and just give us a brief question. So as you get your thoughts, just put it down, okay? So I'm going to not waste any more time. I'm going to go with the person who's traveled the longest to come here, I think, Father Thomas Cullen. Yeah, can we have mics for the panelists, please? So for those of us who don't know him, Father Cullen was the, give the mics. Father, you can sit also if you're comfortable. Okay. Yeah, you can sit and talk.
No, I can talk.
You're okay? Okay. So he was director of St. John's Medical College. That's one of the angles we are going to grill him about today. I can see Cecil Ross really happy about it. And he also taught us medical ethics. He's a world authority in bioethics, which is there. So we're going to talk to him about that. So Father Cullen, if you just give us a brief overview of the challenges that you faced as director.
As
director, yes. We'll come to ethics in a minute.
Not about ethics.
I'll come to that later.
In simple language, the greatest challenge I faced as director here was I was aware of the mission statement of St. John's. They shall live because of me. Don't say he. I come from a kind of culture where this is forbidden, okay? They shall. That's what the original Bible statement, he who receives me, no, the one who receives me will live because of me. That means they, okay? They shall live because of me. So I was aware of that fact. So quality care for the needy. That is one aspect. And I think it was being done at that time. My worry was, as director, my job was to take care of the caregivers. And they say, you pay peanuts and you get monkeys. And I used to say every year, we pay peanuts and we get lions. But it is so unethical that their families have to suffer because they are working here. We priests don't have problems with families and all that. We can, on a stipend, we can exist. That was my greatest challenge.
Thank you, Father. That I think is coming with a great deal of common sense and honesty from somebody in management.
In fact, PG students, all of them one day came to my office saying 2 of our best teachers in medicine are going to leave and we will be lost. You should do something. I said, I will do something. Immediately I called the doctors and they said, we are very happy at St. John's, the mission, everything, but why should we punish our families because of our dedication? Yeah. You know what I did? I introduced immediately, oh my God, it was hard work, incentive system. And I asked them, what is that they are offering you? I said, if we give you that, you will continue. How can you give us? We are 700 doctors here. I said, leave it to me. And we introduced, and they stayed here. Sadly, one of them left recently. Died. So that was the challenge I faced, actually. Looking at the whole thing, St. John's, what a beautiful place. I traveled all the way only for this, just to see the smiles of people here, from fourth-class employees to doctors. What a beautiful place it is. You are doing a wonderful thing. My challenge was this, how to remunerate you justly.
Yes, Justice in fact, money is going to be discussed for a large part of this afternoon's discussion, because Dr. Ashley also has very, very valid arguments in this. So moving it away from St. John's, moving it to a country level, we know that the budget allocated is really, really small for healthcare. and it's actually on the way down. So as someone who was in administration, I know we can make a noise about it, but what else can help administrators across in different kinds of hospitals, not just St. John's?
Where Dr. Ashley's son is now, Vanderbilt University in Nashville. I see they have branches, small branches, everywhere in Tennessee, and even beyond Tennessee. And your rural service, we have one for training our students in one place. But if St. John's can get out of St. John's and go to all these places, Hullies and all that, and have once or twice a week some clinic for people, maybe reaching out.
Yeah. Thank you, Father. I'll come back to you, Father, with the other question. Dr. Ashley, I'm coming to you. Dr. Ashley DeCruz is a Johnite and the man who created the Department of Pediatric Surgery in many hospitals, not just in St. John's. I'm also a product of his. But he's also in charge of the Women and Children's Hospital wing of Narayana Hridayalaya. So he wears many hats. And he's worked in many different kinds of healthcare environments. So, sir, can you go with your opening statement?
Yeah, first, thank you very much, and thank the organizers for this, for having me here and being able to share something with you. I've just noted down a few points because as we're celebrating, old age, 71, we shouldn't forget things. Yeah. So I've had the experience of working in 3 different domains. I'm a product of St. John's. I worked in St. John's for 22 years. And as Robert said, we started the pediatric surgical services and the MCH program here. And it was a very gratifying time in my experience here. Then, for reasons I will share with you, I moved to what was a hybrid system. Somebody who was planning to serve large numbers at a reasonable cost, but at the same time needed to progress and develop and innovate. So he used a phrase which stuck in my mind, and I'll share it with you. He said, charity is not scalable. And that's very important if you look at it. Even in St. John's, in the first years, I remember Father Percy, Father Kalam, struggling with finances to just pay salaries. And Father Percy's great fund, I think many of you will remember. So we didn't have the money to really scale up and grow. And that's why many looked elsewhere for opportunity. So when we moved to Narayana, which is a hybrid sort of system, he very quickly realized that if he wanted to become 17 hospitals in the country and 1 in Cayman Islands, in 10 years, not in 60, in 10 years, you needed to get a whole lot of money and be able to deploy it usefully. They don't make great profits, they make a marginal profit, which is acceptable in industry, and they deploy all the money back into institution growth. That's one reason why many people stay with them. They're really good. And they pay very well, so families could be looked after, children could be educated, and elsewhere. Lastly, I had the privilege of working in England, as well as I have friends in the US where I collaborate with them. I must tell you, the English system is perhaps the best system if you really want healthcare delivered. The American system, not so. I don't think America has got the right health system. If you have money and if you're in the right place, you get very good care. But there are large numbers who don't get that privilege. The English system is a little labored because it's got huge patient load, but ultimately on human balance, it is probably the best way to deliver medicine. That is by National Health Services. So I'll stop here because these are the 3 sort of domains that I worked in, and these are the 3 or maybe 4 issues that I encountered in this period.
Thank you, Dr. Ashley. We've had a little bit of chatter from that side, and you can see money mattered a lot. But there are people on this side where money matters a lot, but in a totally different context. I'm going to ask Dr. Shailendra to step in. Dr. Shailendra Hegde is a Johnite postgraduate in community health, and he works with a large organization. You mentioned about that. And he's helping governments in UP and in the north and mid of India. So he's going to come with a totally different perspective. So talking about
Thank you. Thank you for inviting me over. I work at an organization called JAPIGO, which is actually an acronym for Johns Hopkins Program for International Education in Gynecology and Obstetrics. And the organization was set up in order to build the capacity of healthcare workers in Asia, Africa, and other parts of the world by Johns Hopkins University. Today, we're working in multiple states, and two most important states for us are UP and Bihar, roughly about 25% of India's population, and contributor to largest amount of mortalities and morbidities across the country. So I think the biggest challenge in at least these two states is one, public health system is not able to deliver the services to the population at large because of the sheer size. You mentioned about scale, sir. Absolutely clear that India has probably not failed in innovations, but has failed in scaling innovations. And for scaling innovations, you must have a business model that is workable, that is not going to run on charity. I completely agree what Dr. Ashley said. I think in the public health system, there are obviously different challenges in terms of access, but one big challenge that continues is just the sheer lack of facilities, lack of health system, healthcare workers in many places across these two states. We've been involved in rolling out about 30,000 health and wellness centers in both the states combined. And out of the 30,000, I would think less than 20,000 now have a community health officer who's actually able to provide quality services. Now, even though that number is 20,000, it's not that simple, right? There are obviously challenges where the community health officers are not available, they're just available on paper. There are challenges where the facilities are not accessible by road, the facilities are not accessible by, because there is a social challenge, the CHO belongs to a different caste and I belong to a different caste. I can't go and be examined by a CHO. That's a very true problem that we face. And then, of course, the challenge of out-of-pocket expenses, which is very high in many of these states. One big challenge which I see, and probably a solution as well for that, would be very little private health sector. Large corporate hospitals or large private facilities are still lacking in these two states. And they are run by, there are private nursing homes, but quality of care is a question mark there. But if governments are open to, and if private players are open to, then public-private partnership models for large-scale deployment in the states would probably be a solution, Dr.
Thank you. So Dr. Ashley mentioned 3 domains that he was talking about. And you brought in 3 things which are barriers. Most people think only money is a barrier, but even social factors are a barrier. And sheer physical distance is a barrier apart from money. Wonderful. So going from you to someone who's actually on the field, Dr. Sister Blanche is working in a small hospital and she heads an organization called SDFI who look after sisters who are association of sisters, all of them working either single doctor or 2-doctor hospitals out in the periphery. So I want to hear from you the practical difficulties that you're facing and what you might see is a way out of it.
So, thank you, sir. I am here on behalf of a huge force that is behind me, about 850 sister doctors. We are linked in a fraternity and we work in 8 different regions, carrying out these Samaritan humanitarian services in really underdeserved areas of our country. And I'm really proud of our sister doctors doing really wonderful services, especially in the northeastern part, in the northern states of our country. And coming to the challenges that we face, like most of us are single-handed, as Dr. Antony Robert already mentioned. And one main challenge that we face is the presence of quack doctors that we have in the villages. Like we are planning to launch out into a project of screening and awareness programs of non-communicable diseases in villages, especially in rural, remote areas. Because many times when we sister doctors sitting in our clinics diagnose a patient as a newly hypertensive or diabetic, we start them on medications. Then after 2 weeks or after 3 weeks, the quack doctor checks his or her BP or sugar and tells it is normal, you need not continue medicines again. And then we see the same patient coming after a couple of weeks or months with complications. So we wonder why this has happened. So taking the history, we notice that there's a presence of a quack doctor who's disturbing the health system. It is a major challenge for sister doctors working in remote villages because the public, the villagers believe in the quack doctor more than us. So for us to get familiar with the population where we are serving, many of our sister doctors are there over a period of so many years that we stick, but some, those who are newly going to the place, for the villagers to get acquainted to them takes time. So the presence of these quack doctors and the force that they have, the influence they have on the population is really a challenge.
Yeah, so it's important to listen to such different perspectives. I'm sure you and I are also surrounded by quack doctors, but it's not something that we think of primarily as is there, but for you, it's the primary problem which you're seeing, defeating what you're trying to deliver out of competence. Wonderful. Shifting now to Naveen, the first question is not going to be directly related to your hospital experience, but coming from Sister Blanche's perspective, we see a very different healthcare system. Let me talk about Bangalore, where we are fully geared to offer quality healthcare services to the countries which are away from us, to patients who fly in and actually get the best of care. They get absolutely the best care, which they can get even better than what they might get in America, and much more affordable cost. Isn't this a contrast that scares people? It scares me as a doctor. It scares me that I'm actually available more to people who are coming in from other places who have to pay a big fee to even enter the hospital. So she's with another population. You're, I think, in a position to look at both and tell me what you feel.
Yeah, thank you. Before coming to that, I just wanted to, in the lighter way, in Father Kalam, you mentioned about being sensitive to genders and all that. As somebody said, if, you know, when we are so sensitive about that, the devil, she must be laughing her head off. You know, as someone said, is it okay to sit and speak? And one of the persons sitting there says, oh, it's all right, but is it okay if we lie down and listen? So maybe just to keep us all awake. I think what you raised is a very, very right question. Yes, it is available. Recently, just last week, somebody said, you know, my so-and-so is in US. No, actually, he was in UK. And, you know, he has to wait such a long time. By the time he reaches there, his back pain is totally gone. He was really struggling. And that's not the best system. Here it is much better. But then here we are good in one sense because we are bothered only about the top 5%, the cream. And to them we deliver the best, and we boast saying we have the best. We're not bothered about the 95%. So therefore, we think it is the best system. It's not relevant to most of our people. So I just wanted to move away a little bit from that and say that it is a very viable, feasible model to have the both and philosophy, not either or. Sometimes it is only this or only this. But just wanted to say both and is feasible, economically viable, it is scalable, and it is economically competent and efficient model. And I may be making some statements there.
So Naveen is not coming from a point of view of a theoretical answer. Because what he's talking about, the and or, the hospital that he has headed in Bangalore Baptist Hospital, at this point is actually very successfully walking both boats. I also go to that hospital, and they serve a large number of poor patients who actually reach them, but they're also catering to a group of patients who pays for the rest of them. So he's coming in from an absolute point of authenticity, because he was director when that system was settled, and it's running well. Continue, Naveen. I just want to validate that.
So, you know, it becomes a self-sustaining model of cross-subsidy, not neglecting either group. And that it is a model where you are able to attract people, retain people, pay them reasonably well, may not be as much as what some others are able to do, but reasonably well. And they have confessed and they have said, we find much more satisfaction and it's quite reasonable, we are okay. And that it is able to reach the poorest of the poor, and it also attracts, let me say that it also attracts people who would like to donate and be part of this system. Now, saying that if you depend on donations alone, it's not viable, that is true, but a small but significant portion still comes when they see that there is credibility over the years and that being delivered. So just wanted to make that statement, saying this is a sustainable, viable, scalable, and efficient system. That is just a submission.
Yeah. So, but Naveen, staying with because we're talking about challenges. Challenge I see is that there is one Baptist hospital in the capital of this state. So you're still catering to a very small number, no matter how efficient and scalable we make it. And I think that is going to, the answer to that is not easy, but we need to ferret out the answer from each of our thinking. So where do you see that going? How do you think that you can solve that challenge? The fact that we are still an ivory tower. Even if you're offering the best, you're still in an ivory tower.
I think that's a very relevant question. So, I'm just thinking of one particular hospital in a rural part of Tamil Nadu, where they decided, yes, we are in the mission hospital milieu where we have to really serve the poorest of the poor. But time has come, we have to get a cath lab, we have to get a CT scanner. Yes, it will be, there are a lot of fears as we do that, but that translated to them being viable in one sense, because suddenly the perceptions, the demands, the ask of the community is changing. And if we do not respond to that, we will be the fiats and the ambassadors of our country. And believing otherwise is fooling ourselves.
Fantastic. Thank you, Naveen. Thank you very, very much. Okay, we've spoken about public health, we've spoken of the private health care, we've spoken of administrators. We now come to the bad side of the equation. We're going to cross the line and go on to the side of the corporates. You know, when the public looks at us as doctors, there's a lot of anger because they think the doctors are fleecing the patients. The doctors feel the hospitals and the corporates make all the money. The managers feel the corporate companies make all the money. So I invited the devil himself onto the panel. Gijo James is another Johnite and a very close friend. He's the Chief Medical Officer of Johnson & Johnson Global. All right, so we've got the best of the best to defend the indefensible.
Forgiven, right? No, so thanks, Robert, for having me. The first thing I have to say is, while I'll use some J&J examples, these are my views and not that of the company. I think just in the statement that you stated, right, the commonality between physicians and providers and us is patients. The commonality is that we're all working towards ensuring better outcomes for them. In fact, if you look at J&J specifically, before the company went public in the early 1940s, the then chairman wrote a document called the Credo that defines our values. And the first paragraph of the Credo talks about that our primary responsibility is to our patients, the doctors, the nurses, the fathers and mothers who use our products. So we're all on the same side is where I'm going to. And I don't think we're corporate, we're life sciences. We're in the life sciences business of trying to save lives and increase the quality of life. Now, when it comes to costs, I think that is a common challenge. You and I just had a conversation. You said providers see themselves as being only 10%, so 10 cents on the dollar or 10 paisa on the rupee. When you look at innovative life sciences costs, they're about in the same range. They're 10 on the dollar. So where is the rest going? In the US, the challenge specifically is because we've got multiple intermediaries. And there are multiple business models in the name of managing risk. because the patient is not paying directly to the physician, it's going through somewhere else, the relationship is between you and me, the physician and the patient, but the physician is getting money from a third party. It's broken. So there are multiple challenges around this.
Okay. I'm going to come to Maya in just the next question, but because you said the American health system, Dr. Ashley, I'm coming back to you. Somehow I feel that as a country, India, we're trying to emulate the American model rather than a socialist model, whereas I think the socialist model probably offers better health care. What are your thoughts, sir, on that? I'll begin.
I wanted to say something else, Robert, if you don't mind, before
But you'll answer this point.
I'll answer this point.
Yes.
You'll remind
also,
me about it.
I will do.
We are about 300 to 80, 400 million middle class people in this country. And they've all emerged from low incomes to fairly good incomes. And they all demand of us the same standards of care that are available elsewhere. And that is why every hospital that is outside here as NABH or is now aspiring to JCI levels. And to do JCI and do NABH calls for a tremendous amount of capex investment and public and partnerships with companies to be able to reduce costs and make available all the standards of equipment that are available in, say, any advanced country, because patients demand it. These resources are available, and that's what I wanted to say out of what my comment is, that these resources are now available. They were not available 20 years ago or 15 years ago. Indian insurance companies are much better than what they were before, and they pay. They're not the ones who hide behind the small print, and they pay. So if they are tapped appropriately, most hospitals can deliver quality care to this large middle class. The money bags in the private sector, which I would refer to as big private companies, participate with these hospitals in providing the capex expenditure. Recently, we bought a robotic machine. We didn't pay for it. We went to somebody who has the resources and gave the case, both in business case as well as in the humanities case, of why it will be useful to have this sort of technology. And they paid for it. So that's another source. The last source, I think, is the government. The government is not sleeping. The government has woken up to the needs of healthcare. So with Ayushman Bharat, which is available to all below the poverty line, money is there if hospitals can utilize it properly. And one point I'd like to add to Sister's comments in the first opening statement, before I forget, because I tend to forget these things. We are not, as a St. John's Hospital, we are not doing the hub and spoke wheel model. We have got nursing homes and sister-run institutions all over the country. We should be their first point of reference. But they go to Amrita, or they go to Chennai, or they go to the north, or to the institutes. If they need a high-end care, we should be able to provide affordable top-end care to them first. I rest my case there.
Fantastic. Thank you, sir. Coming now to Dr. Maya Theratal. Dr. Maya Theratal wears many hats in real life too. She worked primarily in the American hospital system, but she's also worked here in India. She's volunteered in India and worked. And do you want to go with your opening statement? Yeah. We've all spoken about, we've all spoken about hospitals and profit and public health. But is it on the mic? Somebody? Yeah. But we've not spoken about the physician themselves, or the doctors, or the healthcare personnel. Right? So one of the points you had mentioned was about burnout and taking care of the care provider. So do you want to go with that first?
Sure. So initially I was actually going to talk about the fact of what I do, or what my focus in medicine is.
Go with that.
So I do physical medicine and rehab, and in general, whether it's in India or in many countries outside India, it's not really a field of medicine which most people know about. So the utilization of a field of medicine like that is very less in most places. So I want to go to a couple of things that actually other people were saying. So, you know, when you buy a very high cost piece of equipment, many places there's no necessity for that. Not just in India, but anywhere. So when you look at it from a rehab perspective, there are a lot of very, very highly costly equipments like robotic devices where you can put patients with spinal cord injuries on. And India, actually you will be surprised, is one of the places which has the most number of locomats. That's a big robotic device which will move both the upper and the lower limbs and make people, simulate people to walk, available in private homes. So most other countries, of course, you might find these equipment in big hospitals and people using it when they go over there, whereas many places in India, because of the money which is available, private people have actually bought it and keep it in their living rooms. Many of those places, because I know some of these patients who have come to us for treatment in the US and then come back over here, it basically sits there without being used after the first 3 days of the use and that novelty of the device. So sometimes I just feel that you know, highly priced equipments are not needed. I tell patients of mine in New Jersey that all you need when you come in for, say, a stroke or a spinal cord injury is an extremely good physical therapist who has good hands. You have a mat and parallel bars. It's not hard to have a mat and parallel bars in any place. It costs less than 1,000 rupees maybe to keep it somewhere, or very less. So what I'm basically saying here from the rehab perspective is you can make use of low-cost equipment anywhere in the world, especially in India. But the problem is the knowledge of how to use it, and also the less number of people who have the knowledge to use it and availability to specialties like physical medicine and rehab in the appropriate way to use it for a bigger population. And people with disabilities in general are a population which get very less healthcare, less accessibility, difficulty to reach to places. But as the unit of hope over here has shown people, especially with children with disabilities, is that you can have, for much less cost, children with disabilities to come into one spot, be seen by multi-specialties on the same day or within 1 or 2 days, and then be sent out like the hub and spoke system, where the spokes are out in the community, and the community people are trained appropriately, like Deepthi does. I'm pointing out to the people in the audience who already are doing this. If we can do it for children, we can do it for adults. It just has to be in the system.
Thank you, Maya. I think Maya's pointed out one of the paradoxes of Indian healthcare. We have absolute paradoxes. We have the highest population in the world, and we also have the highest number of fertility clinics. We have so much money being pumped into fertility to have many, many more. We also have, I had a student from Germany who had come down to spend a few weeks, and he was actually part of an NGO raising money for India because of poverty and starvation. And he took so many pictures of the weight loss clinics that we have here. He says he just cannot believe that this country has both. You have weight loss clinics and you have starvation and people raising money. So it's a kind of a mirror to the paradoxes which are here. I'm going to hold you to your second point about disability before I go on to the other side of the panel. You had a lot to say about the challenges in disability which you see.
So again, the challenges in the system over here. So in context, it's like I was here for 2 years actually in St. John's in the Unit of Hope. So that's why I'm like taking reference from there and using it towards the adult world. Again, for people with disabilities, accessibility to healthcare is probably one of the biggest things. no matter whether it's here in India or any other country. For a patient to come for just one hospital visit takes a lot out of not just the patient, but all the family members or whoever is transporting them. So the availability to be able to get a comprehensive health checkup or whatever needs to be done in one visit, I think is really important. So like a patient home for people with disabilities is what I would envision. Something like in the model of what we do in the Unit of Hope here. If anyone was there yesterday, Dr. Saji said the reason that they actually started the Unit of Hope here was a lady who brought in her child and was here from 9 o'clock till evening and still had not seen all the doctors that they needed to see. So I think one of the biggest things is to be able to have the patient have the opportunity to get the most number of things in the smallest amount of time in the most efficient way. And that's why I brought up patient homes.
Thank you, Maya. We'll come back to this again, hopefully with a different perspective from somebody else. But now I call upon our youngest panelist, Dr. Prithvi Dasri. He's a Johnite undergraduate and postgraduate person. Pulled his weight during the COVID wave, so he's going to spend a little time on that. But most importantly, he now works in a sector of healthcare which is upcoming and about to boom, or already starting to boom. So he works for a company which is Cloud Physician, and he's one of their top doctors. So they don't actually touch patients. I went to his unit to see. So standing in one spot on a tile, he was dictating treatment of about 50 to 60 patients across the country. So the question coming to you is, A, what is the promise of technology? Because that is exciting for all of us to hear. And also what troubles come with using too much technology in healthcare?
Thank you, Dr. Robert, for having me on this panel. It's a very august panel. Before I get to your question, I just want to introduce myself and where I worked. I did my MBBS, went on to do my rural service. I worked in a village which less than 5,000 population. The closest metropolitan city is Bangalore. From Bangalore, I had to take 5 buses to get to the, so that's how the connectivity was. I came back to John's and did my MD medicine. And I worked right at the time of COVID, first wave. Just before that, I finished my medicine and jumped right into the wave. And I worked through all the 3 waves of COVID in our critical care. And subsequently are currently working with this organization called Cloud Physician. So to string all the thoughts of most of the speakers on this panel, I do have a perspective of the rural health. I have a perspective of the hospital like John's, where a lot of patients, I'm a physician at heart, so a lot of patients, how patient care is done in St. John's, and a little experience outside. And coming to the technology, what Cloud Physician is doing right now, the hub and spoke model, that is exactly what we are doing. We have partnered with close to 100 hospitals. Last week we touched 100. So over the last 6 years, 100 hospitals, we've managed to treat close to 80,000 critical care patients. And some of the hospitals are in rural Jharkhand, rural Bihar, and some of the places where primary care is not appropriate. And that is the place, we are not waiting for them to come to the hospital. We are going there and delivering the care. How are we able to do it? It's the technology. One other statistic I would like to mention is over the last probably decade or a little less than a decade, 82% increase in the medical colleges, 110% increase in the MBBS seats, undergraduate seats, 124% increase in the postgraduate seats. We are increasing rapidly. Still, we are only scratching the surface because the problem statement is that big. The only way we can at least one step closer is technology. So that's something I want to mention up front. Coming to the challenges, yes, adoption is a challenge because for somebody who doesn't see me in person, are they confident enough to take my word? Maybe not. But without going there, can I help them? Yes, definitely. We have shown the data. There is data out there. There's a lot of publications which came from Cloud Physician. So, yeah.
The data is very good, data is very exciting and promising, but I still worry about the lack of a human interaction, which I think most of our patients would still crave. So after you finish your counter to that, I'm coming to Father Kalam.
So about that, we are never going to replace the bedside team. So that's clear. What are we going to do? We are going to augment the bedside team. The bedside team can do procedures. They can intubate the patient. They don't need a lot of skill for that. They just need a little bit of experience. Central lines, they can do it, not a problem. With the expertise that I can sit in Bangalore and tell a patient in rural Bihar what needs to be done, at what time the patient needs to be intubated, what time patient needs to be extubated, that is where we come into picture.
I think so. We need to also strengthen the local manpower who's delivering there, not just with technology, but a lot of empathy and compassion, which I think will slowly move away with too much technology. Dr. Ashley wants to counter.
Just want to clarify on.
Yeah.
Do you encounter any regulatory or legal issues in providing this technology?
So far, we have not, because these was completely adherent to the central government guidelines, the tele-ICU guidelines, which has come by central government of India, 2020 March. So far, since we've partnered with 100 hospitals, we did not come across, and some of our biggest organizations like HCG, we're partnering with HCG, their legal team has pre-vetted the organization and the work.
So when you give prescriptions or you give advice, it's legally acceptable?
Yes, it is. Because the bedside primary team, a patient is admitted under the physician at the bedside, right? Patient is admitted under him, and we give the advice. It is an RMP to RMP model. A registered medical practitioner to registered medical practitioner giving the advice.
You've not yet been in a legal litigant case?
No.
Don't worry, Dr. Ashley is only asking the question. He's not pointing to anything more. You want to? Okay, sure.
I'm just clarifying.
We do a lot of work with...
You're on, Shailendra.
Hello? Yeah. So we do a lot of work with e-Sanjeevani, which is the telemedicine program from the Government of India. And e-Sanjeevani actually followed the guidelines which Prithvi just spoke about. So as of now, a large number of cases are being seen through e-Sanjeevani, and from at least the data that I have with both UP and Bihar, we have not had any legal case. But I dare say that it is around the corner. I don't think so the problem that has happened is that we apply the principles of physical interaction with the patient to a the same legal principles are still applied to the teleconsultations. And so there is a problem. And that needs to still be countered by legal luminaries. And I don't think just the government guidelines are going to solve that problem yet. We are lucky that the government is very strongly behind this.
Backing this, therefore
and therefore it is kind of sailing through.
Yes.
That's what I feel.
Very good, thank you. So, Father Kalam, coming from the use of technology in humans and the points which the others have made, bioethics was your core point, right? You were a professor of bioethics. You taught us that before you came here, and I thought it was something close to your heart. So how does bioethics relate to A, technology coming into medicine, and two, in the real practical world of corporate healthcare, the practical relevance of ethical healthcare delivery? Because this is out of the textbook. This is coming on to delivery.
In healthcare, from time of Hippocrates, 5 centuries before Christ, healthcare was closely associated with ethics. Ethics, in fact, healthcare, every doctor must be a philosopher, according to the doctors from time immemorial.
Incidentally, my website is called The Surgical Philosopher. Thank you.
Last 5 years, a big revolution is taking place in the States. Bioethics started maybe in the present form in 1970s. Carrera and Quinlan case and all those things were the points where it had to develop like this. But it was institutional ethics, and sporadic cases were discussed. related to beginning of life, end of life, and some in-between cases and like that. Things have changed now. Now, VA hospitals, 1,500 of them in America, they did some studies, and there are at least 60 lakh patients are being treated in these centers. So they have introduced integrated ethical bioethics in healthcare, without which it is not going to happen. What is happening is we can discuss the sanctity of life before birth, but the problem is once it is born, there is no respect for that. Only in an institution where there is a real respect for human life, we can discuss sanctity of unborn life. But very often that is neglected actually. And when we come to remuneration also, it's also part of ethics. Actually, you take care of people. Only in that context we can discuss ethics. Yeah. So they are introducing it. In St. John's, we were doing it practically from the beginning actually. So the solution is administration must be involved in ethics, where ethics is applied. One simple case I can say is once some notice was put there according to which students cannot use the lift, and fourth class employees, the poor ladies who sweep and all, they cannot. And they all came to my office, and I mean, it is so unethical to ask them not to use the thing. In an institution where we have no respect for people like that, we cannot discuss other type of ethics.
Therefore, it has to come into everyday working of the hospital.
Yeah. Now they are introducing this kind of integrated ethical approach in the hospitals. I think we are more or less committed to that.
Wonderful, wonderful. Thank you. Thank you, Father. Moving naturally from there to Naveen, because again, you are also exposed to the CMC Vellore way of working, the hub and scope, catering to the poor and the rich. But what are the ethical problems you've seen running in that system and in your own health sphere? Because you're not truly in the corporate tech sector where we are, but from your perspective about ethics again, practically, in a practical use of the word.
I think one aspect of this struggle or tension between the two comes in the allocation of time, because the affording demand more time and the other segment tends to get, because they do not demand as much. Now it's countered now because, partly, not fully, because they also do demand right now, which is a healthy thing, because they also know their rights, and so it is not as bad as maybe 25 years ago, where they did not know their rights. So the other thing is the need to keep on repeating to our own people and every batch, and also refreshers, saying he and she, the one who can, the Kupama, the Muniyamma, the Muniyappa, those who are not able to raise their voice, they are the VIPs. Yeah. We also serve the others. Yes, they help us make it sustainable. And this thing being repeated often is a reminder to ourselves. We need to hear, and every new batch needs to hear. It cannot be adequately repeated enough.
Correct.
I think
that brings me to medical education itself today. I think they also need to hear the challenges from the people working outside in the real world, because 80% of them, I think, are going to find jobs in this sector outside a medical college. So these are the things they need to actually build into the curriculum, even as a guest lecture across the country. One small anecdote, since you said Kupama, I remember a similar Kupama from Hindupur who approached me about 5 years ago. Grandmother with the sari, check sari tied between her legs, so you know who I'm talking about, speaks only Telugu, not a word of any other language. Brings a grandson for something with the testicle. So I always ask, I said, where did you come from and who referred you? And she told me in Telugu, Google la chusnenu. So I was incredulous. So I said, how did you do Google? Where did you do it? So at the public bus stop, catching the bus from Hindupur to Bangalore, she went to the STD booth person, gave him 10 rupees and said, my grandson has this problem, who can I see in Bangalore? And that fellow just gave her a printout with 10 names. I happened to be the 5th or the 6th, but then she landed up. Now that, I think, kind of is also the way forward for them, because technology has reached even someone like her, who doesn't have to touch a smartphone or a computer, but still be empowered. And I think that is a bright way forward. But Dr. Ashley made a very interesting point to me. He said that we are increasingly looking at the patient as a money pot. So I want to stir that pot before I come back to Maya. Let's listen to you on that, sir.
This is related to the issue of ethics, or ethics in practice. Being in the sector outside St. John's, I'm aware, like for instance, I walk into my operating room, which is about 5 theaters on one floor, and I say, how many normal deliveries today? I joke, because what the normal deliveries are C-sections. And the C-sections have gone from any teaching hospital would have maybe 20% is acceptable, recommended, guidelines. All private hospitals exceed 60%. Now, what is the ethical issue in that? Every little boy who has a foreskin has a circumcision. It's a simple, safe operation to do. And in the city of Bangalore, everybody has phimosis. Every child has phimosis. But it's cost. It's cost, straining the medical system and taking away time and, procedure time from somebody else who might benefit from it. Like this, the stories are umpteen. And I'll say a few provocative things. Ventilating a patient who's already brain dead and not willing to give out the organs. Staying in the ICU for a prolonged period of time, waiting for a bed in the ward to get cleared. These are all tactics or methods that people use, which I'm aware of, to augment the income from each patient. I know it's provocative to say it in this audience, and probably it's put me online, So, but that's the truth, and the truth hurts sometimes, and the truth is painful. So as a medical fraternity, how do we strengthen ethical practice? So when I want to do an operation, which is an invasive procedure on someone, I must be 100% sure and justified in doing that procedure.
Thank you, Dr. Ashley. Maya, coming back to you, and after that we will open up the questions to the audience. If you have not a question, just put your hand up. I'm very concerned about physician burnout, especially in India, the number of suicides amongst healthcare personnel, young doctors, middle-aged doctors committing suicide because of stress, postgraduates committing suicide because of stress. So from you, we'll move to Prithvi, because he's the young doctor on the panel. What is your viewpoint on this for people who are in practice, who are actually on the field and forgetting to take care of themselves?
So definitely we have to take care of ourselves, and that's really important. And generally, as doctors, I guess, and all of us who have gone through St. John's or other institutions like that, we really highly regard the fact that we are out there to help people. And it can be the other way also. If people are out there to think that as a doctor they have to make a lot of money, that also puts a lot of stress on them. So there are two ways I think that people put stress on them. One is because of the fact that we feel that we, with whatever resources that we have, that we are not able to give the appropriate amount of health care to the patient, or also that we want to be perfect. So anything less than perfection is stressful to a lot of people, especially very smart people. So some of the parts is I think we need to rethink the fact that we should not and cannot hold ourselves to extremely high standards. We should know when to know what the limits of our capabilities are, and to be happy to stay within those limits. So, train yourselves right from the beginning for that. Another thing that a lot of people, doctors, and especially I think women doctors do, is we take upon ourselves a lot of things. We do not know how to say no. And that is something that we need to learn right from the beginning. How to say no. It is an art. I'm one of those people who finds it very difficult to say no, but I can say that in more recent years, I've been happy. Yesterday, someone asked me the question. I'm in private practice now. I used to be in academic medicine. And, you know, there's no real ladder for me to climb up other than the fact that maybe I can make more and more money all the time. But it was a very relevant question that person asked me. Said, after years, don't you feel that you need to climb that ladder of becoming a director or becoming the chairman of a department or chairperson of a department? That's something I think I gave up 10 years ago, actually, when I came to India and spent 2 years over here. Some of that thoughts in my mind I was able to pull back on. So it was one step in a way to tell myself, don't kill yourself to do multiple number of things. And I think that's the most important thing that doctors should do. And from an Indian perspective, I have to say, I probably would die if I would work 6 days a week. We really need to cut back on that. We do need 2 days of a week to rest, to give ourselves some breathing space, especially in Christians, because we take the Sunday off. And remember, most practicing Christians go to church pretty much most of the day on Sunday. And there's a lot of responsibilities that you do. You don't really get a lot of time to do anything else.
I'm glad you didn't say there's a lot of stress in going there, because Father Kalam's eyes were dilating. Yeah.
One point too.
Sure.
So I think there is a need for the doctors and healthcare workers outside of academic institutions to form a group, form associations, and try and build these some of these elements in their practice.
Precisely where I was going.
Yeah, especially and I think it happens in some of the tier 2 and tier 3 cities as well, where they may be members of Lions Club, Rotary clubs, and those kinds of associations. But I think in the heartland of the country, I don't see those powerful associations, influential associations to take care of the fraternity. I dare say that.
I'm very happy you brought it up, because I'm part of the Indian Medical Associations. We have a cell for well-being, because the number of suicides alarmed them 3 years ago. And now actually every IMA, the local IMA in tier 2 or in tier 3, they very religiously every 3 months have one session dedicated to talking about depression, talking about challenges, talking about taking care of themselves. So it's become mandated by the IMA. But when we try to do it in the city of Bangalore, the attendance on that day is minimal, because somehow here you won't find time for that, because you're probably stressed out about healthcare.
But I was more talking about not just the monthly sessions, but also are there doctors and healthcare workers in smaller towns playing a sport together, or watching a movie together, or spending time together? I don't see that happen in
the big city.
Actually, even in the smaller cities, I don't see that happen so much. Especially, I'm talking about UP, Bihar, those kinds of places. I don't in the smaller towns. In the capital cities, it happens. If you go to Ranchi, you'll probably find a good association of doctors probably doing something together, which is what I was referring to.
So I think the one takeaway from just this point will be, I think more of us, whichever sector we work in, should I think have the courage to talk about mental health for ourselves, for physicians. I remember the BMJ carried an article when I was a postgraduate in pediatric surgery. It was an editorial about an anesthetist who was writing about his own depression. And my own reaction to the title and the article was, what a foolish fellow. He's such a senior doctor and he's got depression. How can it be? And I think so that's something that some of us grew up with. And finally when it hit me, I realized that it can hit anybody. And I think that's why I think we can make a personal commitment, not just for ourselves, but maybe in a team. You're running a department, you're running an organization, you're part of a small team, your nurses look up to you, is to be open enough to talk about it. I'm moving to Prithvi before I come to open up to the audience. So Prithvi, as a young doctor, right? So your training here equipped you skill-wise, right? But what other challenges did you face during your training which left you feeling a bit unequipped when you moved into the real world?
The skill set, definitely, you are very, very well equipped. You know your medicine, you come out, you do your thing. But what is lacking out there is, okay, how do I put this skill set to use? Can I make some money with this skill set? How do I manage my finances? How do I talk to people? I don't know how to communicate with people sometimes, right? You're busy doing your patient care. You don't know how far the patient has traveled to get to the hospital. Right? You don't see that side of it when you're in the hospital. So these are the challenges when you go out. The soft skills are hugely lacking. I mean, this I say with the first-hand experience because I get calls in the middle of the night from students who are doing their rural service. They are so poorly equipped. I'm not talking about St. John's. There are rural service which is happening across the country. Middle of the night call, I don't know how to treat diabetes.
Sorry.
Right? It's not that they don't know how to treat diabetes. They were taught well, the theory. They were not practicing it. Here, like the senior consultant is taking care of it. You're writing the orders. Right? It's a huge gap between the learning theory, going out there and actually practicing. For the first 6 months into our rural service, we are dumbfounded. We don't know what to do. Call that senior you're close to. Call that consultant you're close to. Call them frantically and say, what do I do now?
So you want to share with us a solution you have for this problem?
So I think they should be much more hands-on.
You're already doing something. I know you're doing something. So tell us about that. Tell us the solution to what you're doing.
So I think we have to empower our students while they are here. When I say empower our students, give them the free hand. Let them make mistakes under the umbrella. Right? So let the consultants, faculty correct them while they are here. Take independent decisions so that they know they are confident that, okay, I know I have made a mistake, I'll learn from it. Here we are spoon feeding, hand holding. It's happening in every medical college to the extent that they are graduated and go out.
So what Prithvi is not talking about is that he is on the field, he along with Nitin, Yashas and Gino, a group of Johnites, they've put in a WhatsApp communication group among all these doctors who are doing rural service, wherever they are, on a daily, real-time basis. They're fulfilling that gap which he's talking about. So then they put it in there, and they form the bridge to other seniors who might be able to guide them. Do we have any questions from the audience? Any of you want to ask a question to any of the panelists? Yes, Dr. Kanishka Das, the back there.
Yeah, am I audible? Yeah, I don't have any questions, but very interesting session. And I noticed healthcare challenges different perspectives. Now, having moved from working here for 20 years onto the government of India, I will add my perspective to it. I think there is, like Dr. Ashley would say, there's a big elephant that we have missed. The key thing that faces us in this country is that we have extremely poor primary health care. Some perspectives came from there. And I noticed that most of our discussions veered around and were focused on barely 4 or 5% of the population. Until the government of India bucks up and manages its PHCs well, CHCs well, enforces the 1-year rural service, we have a 2-year rural service here, that's great, enforces the 1-year rural service, just 1 year for every medical graduate that comes out to go and serve in the periphery. Unless this happens in real time, we are, on a pessimistic note, going to remain like this for a few more decades. It doesn't make an inch of difference what the cream gets and the advances we make in robotics, laparoscopy, etc., going down to microgenomics, etc. Till we address our problem at the PHC and CHC level, till the villager doesn't travel kilometers and kilometers to reach a health center where he will get primary basic facility, I'm sad we are going to remain at that level. So by hook or by crook, by whatever way, the government of India has huge resources. It must be channelized to that level so that a poor villager can reach out to a PHC, CHC and get his basic care. That I see as a major challenge in our healthcare.
Thank you, Kanishka, for shining light on that. Dr. Shailendra, I would think the solution for this would be a change in policy, something that we may not be able to talk about here. But apart from policy, budget allocation from the government, from what I know, is actually dropped to healthcare.
So I think while at proportions it has dropped,
Yeah.
but I think at this point in time, the government of India is actually fairly well resourced in terms of money to be able to provide for at least infrastructure at the health and wellness centers, PHCs, CHCs, and so on. The biggest challenge that the government faces is operations, actual project management, right? There's extreme degree of lackadaisical attitude and leadership skills which are lacking at multiple levels. And I'm not painting a brush across the entire government ecosystem. There are wonderful government doctors and government officials who have done tremendous work. But when you look at it from a population scale level, I think it still doesn't stand up to those standards. Yeah. So in terms of, I think what Dr. Das said is absolutely correct. Until we build that capacity at the lowermost levels of healthcare service delivery, I think we will be a very top-heavy and medical tourism focused country, which is a bit of a bummer for us.
Yeah. Jijo, I'm just going to get you in at this point because you're running a very efficient global organization. And I'm sure it's a very tight ship that you run. In theory, if you were to get this ship, this problem of apathy, as Sir was talking about, of difficulty in implementation, the money is there. How would you do it?
I think the way you need to begin to look at things is by defining value, right? So it's not just quality. What is that quality leading to? If you look at what we do within drug discovery, you begin to invest in areas where you can generate revenues, because then that same thing goes back to feed the engine. You've got to start looking at it that way. We spoke about, and I know we're talking about the cream, we spoke about robotics and everybody is going to robotics. Has anybody stopped and asked the question, what is the value? Where do I use it? We begin marketing to people. So if you bring the question back to value, you can begin to solve.
Could you shake up the meaning of value versus profit? Because I think that gets confused a lot when management thinks of value. So could you just give us
I think both are needed. So we spoke about the creator, and I said there are 4 paragraphs. The first one is responsibilities to patients, employees, second, community third, but the 4th is towards your stakeholders, and I think, or your shareholders. And they exist everywhere. You need to be able to generate profits too, because if you don't do that, you won't be able to sustain the system. So it is a fine balance. There is no magic formula out there. But there is still an opportunity, and I'll use a J&J example. A few years ago, we brought bedaquiline into the market. I think for about 20 or 30 years, there had been no drugs for treating tuberculosis that were brought out into the market. This was the first one for multi-drug resistant TB. We were able to do it because we entered into partnerships with Gavi, with the Gates Foundations, etc. So we shared risk in that system. We were able to keep prices down and work directly with governments.
And get the value to.
And get the value to the patient.
Okay. Any other questions? Dr. Cecil Ross, please.
Yeah. One of the things that I think has not been touched upon is the culture of the people. Now, supposing you take the Western culture, traditionally, they think that health is a state responsibility. They think the state has to be responsible for the citizens. Whereas if you take our cultures, they think state is not, this is my own headache to take care of my health. And therefore, if you look at elections, the major election points are healthcare in the US and the UK. Whereas health is never ever discussed in election as an issue. And therefore, I think that across, whether if sisters saying that quacks have got more hold or sway, it's a cultural problem. If Naveen is saying, or Shailendra is saying that, the lots of money is there and people are not using it, again, it's a cultural problem. And if he says that a person, one CHO cannot see another patient because of caste and culture and so on and so forth, that's a cultural problem. It is not health. So people are not very keen, and I think it's not necessary for us, I think, to be able to enforce health systems on people who are not what should I say, who are not appreciative of it, or who may not need it or may not think it is important. Now, supposing if you're saying that health is important to me. I would not care a damn whether I would go to person A or person B as long as that person delivers. I will not look at his caste or whatever. So I think the cultural issue, correct. Yeah. So unless the culture of the nation changes, and therefore culturally also our budget is in tune with the culture of the people. It's 2% or 1.8% or so now. Earlier it was 2%, now it is 1.6% or 7% of the GDP. Whereas if you take the European nations, or if you take, it's a 30-20%. It's not even touching. So it's not an election point. It's not a point that the population bothers about, and they feel it's karma. It's my own fate.
Dr.
And therefore,
I need you to get into politics. Join the Aam Aadmi Party and change things for us. Because there's been a beginning, at least in Delhi, where they've at least talking about health as a centerpiece. I'm not a member of the party. Dr. Ashley, you want to make a comment?
I'd just like to, add some optimism to this whole rather somber sort of discussion that's going on. There are many states in this country, just in proximity to Karnataka, who are doing very well as far as health is going. In Tamil Nadu, every district hospital, every small place has specialized care for children. Kerala, I think, has a brilliant. So we should not paint the whole country. There are pockets where they're doing exceeding, and they might be the models on which we could spread it to the other states. It's the political issues and the local issues that have hampered the development of these models in those states. And I'm happy that our younger folk are taking it up, because that's all you need to do. We'll say it again. The resources are available. These are changing times. There are more people who have the money to go and access healthcare. I think robotics, I'm sorry I used the word from the first and then it became slightly taken away. I didn't mean it in the sense that everybody could get to, but peculiarly, if you have a robotic machine in your institute or your state, the perception is that everything is possible there. And that is going right through the villages as well. They come and ask for a newborn baby to have a robotic procedure. They've heard about it somewhere. So it's not applicable. I mean, I know it is wrong. I know it is a waste of money. When it first came in America, within a 50-mile radius, there were 50 robotic machines. And they were fighting with each other how to use it. So it was a technology looking for an operation, looking for something to use. So it's not that we have it more for, I think, advertisement. No, it really doesn't do too much.
It's marketing. I've had patients come and ask me for a robotic circumcision.
Yes.
Can I do it by using robotics? And I tell them I'll do a robotic circumcision, but not a robot. Jijo, and after that, Dr. Anthony.
If I could just add to that also, I think the point of optimism is when you look at how far medicine has advanced, Dr. Cecil would attest to this. When we talked about multiple myeloma 10 years ago, you were looking at a death sentence. Today, we are almost at the verge of driving cures towards it. If you look at COVID, and you look at COVID globally, there are lessons to be learned out there. We may have had poorer outcomes in certain areas, better outcomes somewhere else, but we collectively pull through. When have we ever got a vaccine out? In 2 years. And pretty darn effective vaccines. So there is a lot of optimism. We are driving in the right direction. We will get there.
Okay, thank you. Before I go to Shinod, I just want to comment from Dr. Anthony. He's for those of you who don't know, he's a major into medical journalism. He writes a lot of articles about health. So I just want to see if you can get us a question or a comment, Dr. Anthony.
No, a few comments I heard, I want to react to that. One is, Ashley mentioned there's plenty of money. I mean, you meant resources can be generated, but actually in the public health system, our budgetary allocation is still 1.3% of our GDP, which is highly inadequate, and we health activists demand, if not 6% of the GDP, at least 3% of the GDP. And money is there, its priority is not there. We haven't scaled up. One of the arguments finance ministry says is health system did not show the uptake efficiently of the funds already allocated. What's the reason for it? It's the truth, but the reason for it is somebody mentioned about operational. The tiers of health management. First of all, there is no participatory bottom-up planning. It's still top-down. So the priorities of the people, needs of the hospitals it's topsy-turvy. So district health planning, which was the vision of National Health Mission, is taken up truly. Each PHC, CHC doing will be a better utilization of funds, and for which professional management teams are required. And that's what National Health Mission made, and it made a tremendous difference in all the states, including Bihar, Arunachal Pradesh. I've been to all the states except Mizoram and Jammu Kashmir on behalf of Government of India. The little management capacity which is built up in every district and state health management team, apart from the routine directorate of health services and family welfare, made enormous difference. Client satisfaction, quality, and what you call NABARD, NABH accreditation. It makes a difference. So public health system, people are walking into, there are competitive public health hospitals, district hospitals, at Nagala Hospital, Korba district hospitals in Chadi. Because I was responsible for Korba district hospital to get ISO 2000 certification. So it can be done, and India is a fantastic country. If you could become an IT power in the world, we could do similar things, IT application, it can make a phenomenal difference, but priority has to be there, political leadership and commitment should be there.
Thank you.
Close with one more thing. Unless communitization is incorporated in principle and practice, health system will be a technocrats imposed system which won't be people-based. Then only the people's health become in their hands, people's hands. And that's my comment on it.
Thank you, Dr. Anthony. And Dr. Ashley, I think they're building on the optimism which you started, you sowed the seed for.
It's actually gone up. The GDP allocation has gone up a little bit. It's not really gone down.
It has gone down. That is only, but that's not enough.
Proportional.
When we compare it with Thailand or Indonesia, that is where.
Thank you, Dr. Anthony. Dr. Shinod has a question, and after that I would like a question from any of the sister doctors in the auditorium. Thank you, sister. Very
Hi. Okay, it's very interesting to hear all these high-flown ideas. I want to ask a more pragmatic question. I'm very impressed that Prithvi has leveraged digital communications to do critical care from far away. So what my question is, St. John's is a hub, and I see the sisters, doctors working in various parts of India as our spokes. Is there a digital link between our peripheral sisters and the experts in St. John's to guide them in critical cases? And given that we have such vast resources in digital, why has that not happened?
If you're asking the question of the management, I'm not here to answer that.
No.
But I have a question.
It's not a question of management.
The SDFI.
I know. The question is, because sister is here, it's
I'll
not
build
to the management.
I'll build the answer. So SDFI and the Alumni Association have started working together closely in the last 5 years, thanks to Praveen and Maya and the current leadership. Now, with this, what you're talking about, I think, is the path to go. I'm going to ask her to respond first, then I will submit it. You got his question. Yeah.
More than linking to these issues, like many of us, because of the availability of phones in our hands now, and many of us enjoy good networks, so we possibly connect with our companions, our batchmates, or like the present generation with their PGs to settle these issues. For us, sister doctors, what we notice is to go for updating programs, like if you want to upgrade in our specialties, to go for conferences. Sometimes the cost becomes an effect. Most important point is we are single-handed in the hospital. So for us to have an absence of at least 5 days or 1 week from place of work is very difficult. And when we go to renew our registration, we need credit points. So to bridge this gap, we kind of linked with Alumni Association to conduct virtual CMEs for us, which will award a few credit points so that this will enable us to facilitate our registration, our renewal of registration a little easier. This is how we have tried to tackle a few situations. As you said, sir, like we can think of linking this hub and spoke method of connecting many more sister doctors to this digital platform.
Yeah. So we'll build to that, because what it started off was her problem statement. She said, I can't go to get a registration, I don't have points. So what we've now done already and are committing to continue is every 6 months to have enough points for them to get it. Moving on to practical healthcare, to build a network like what Prithvi is saying, will need investment. Will need investment because that is going to be an institutional involvement. I think that we have to work towards.
You know, sister doctors, to make them more effective and active. We have started one forum, Sister Doctors Forum.
Yes, sister. That's what she's talking about. Yeah. Yeah.
To indulge and to get into.
This is Dr. Sister Lillian. She's the founder of the Sister Doctors Federation of India. So let's put our hands together for her because she started this.
Give her the mic, no?
Most of the sister doctors were just coming, working and going. So for them also to have some interaction, and that's why I started the Sister Doctors Forum. Yes. And it helps out. Yeah. Many of the sister doctors to be more effective and active. And also we have another RCOG trust also we started along with this. Wonderful. And it is helping many of the doctors, especially sister doctors and other doctors, to be more effective and work for others.
Thank you, sister. Thank you, Sister Lillian. We're really proud of what you achieved by setting this up.
Both the RCOG trust and sister doctors.
Yeah. Thank you. Yes, I'll come to sister who wanted to raise a point, and Shinod, I'll give you the comment.
Can I?
Yeah, no. Just. Yeah, my point is we touched upon the care of the healthcare providers.
Yes.
To some extent, Maya is present about where to say no and what is our priority like that. But there are some areas like, for example, what is the protection for the doctors where they are, especially in the rural areas where they are working, where they are really attacked by the people, where they are not really cause for it. One thing. Second thing, the workload of the doctors in the institutions, what is the policy behind their working schedule and all that. Including sister doctors, because I was the vice president for 6 years for STFI, and we have done this, Blanche knows about it, we have done the survey on the stress of the sister doctors at various levels. We have come across various points, they have proposed it. Of course, we all know that they all work in single-handed, and because they are unable to take a break, and maybe they are facing with a difficult situation, they are able to handle all those things. How, as St. John's, of course we have certain extent, we have reached out to the rural setup, how we are able to form a network really during these stressful situations, including our batchmates. We have talked to many of them. They are unable to come out in that stressful situations. So how we can help in those areas, whether sister doctors or even our doctors, where they are working in places where they are really unable to reach out. So maybe we have some extent what we can do, but still how we can form a network to help them in their real dire needs.
Anyone feels motivated to answer to that?
I don't know whether it would be a practical suggestion, but just like you have work hour restrictions, maybe the SDFI should take the lead in talking about, I know the need is very high, but the need is always going to be very high, but have actually guidelines in place where you limit the work hours and limit the workload for your sister doctors, just like as if you would unionize.
Can I give a practical suggestion? Can we have a pool, voluntary pool of short-term reliever doctors, gynecologists, pediatricians, on St. John's form. It's like voluntary blood donation. You are willing to, any time you want to go for 15 days, 1 month, 2 month relieving. My own classmate sister, Dr. Claire, a cancer survivor, she's supervising 5 gynecologists. She couldn't be relieved, and that's why she is not with me. She is so much wanting to do. So that as what she said is, that will be a tremendous help. It's both as a stress relief, and it will help them to go for CME programs so they get the credit points. So we need to very seriously think about, as a alma mater, to have a reserve pool of doctors who can go and relieve them.
Hi, I'm Dr. Pradeep Hopkins, 2000 batch. I work as a surgeon in Nuclear Power Corporation of India Limited. I think I had said a message to Dr. Maya, and she had forwarded regarding unmet needs and surgical thing. Just regarding the current thing which you are discussing, I work in the institute. I work in outskirts of Mumbai. There has been made mandatory for people to deputize. I mean, like the pediatricians, the same point he mentioned, to deputize in places of need. One month from different parts, these available pediatricians are pulled into and given a roster, like you go in one place of need and deputize for those people where the people have been overstressed, the work is too much and it's not able to manage. So I think we should consider that as well if it can be practically possible. Actually, working for BRC Hospital in Mumbai, I have seen Dr. Arga Roy. If somebody is well versed with the global surgery, they will know his name. He's a WHO consultant. He used to send every month his surgery PGs to Janswad Sayog in Bilaspur. And that kind of helped build up that currently Janswad Sayog is not so dependent on Dr. Jain, who's the founder. That's basically because Dr. Arga Roy chipped in and helped. And if that can be practiced in our setup as well, I actually thought of asking our own institution. By that time, we were too much caught up with even rotations being cut down in our current batch, I mean the batch which I did my MS surgery here. So it couldn't happen. But it definitely is possible if that has been tried. I mean, that's what my proposition is. I actually had that the whole global surgery thing, which we have done over 36 different countries, all over the lower and middle income countries, which I had written down, but if time permits, I can share the details as well.
I think as a practical working point from Srinod and your point and Dr. Anthony's point, and continuing with what Sister SDFI has started, I think we can move forward beyond just CMEs to talking to the hospital.
Dr. Robert.
And try and get people to.
Can I just ask one thing?
Yeah.
See, I think apart from what all said, my question was, given that the technology has advanced so much and video conferencing and teleconferencing facilities the cost has come down, wouldn't it be even viable to have a teleconferencing link where the sisters can communicate to the hub for help on a regular basis for different specialities? I mean, I think Prithvi could enlighten us.
Yeah.
So Srinod, absolutely we can do that. But I think we're trying to problem solve out here, and it's going to take a lot to get to those. There are ways to get funding. There is technology available. There are different models to resource. Absolutely agree with that.
Thank you. Thank you, Srinod. We are almost at the end of time. Any closing comment? Somebody at the back. Yes, please. Yes, Maya.
I'm Dr. Malcolm Fonseca from Bombay. I'm a gynecologist. I think what Sister was possibly referring to was you get into a situation where you have maybe done a cesarean section on a patient and the patient is hypotensive. You don't know, there's crowds outside the hospital trying to lynch you. Sister, maybe you were referring to that? Then, yeah.
It's not isolated. We don't have anything like that. But
Yeah. Or you don't get an anesthetist and you're in a fix in a small town. I guess you've got to have your own group of doctors over there who can support you. But what Dr. K.R. Antony said, if you are going to be working on it, Robert, in fact, it's going to be enlifting for all of us, a reserve pool of doctors who could help the sister doctors. And when you're doing that, I would suggest looking to doctors who are early retired or something like that also.
And identify them and then see if they're willing to go.
Dr. Antony?
Father Kalam? Yes, somebody asked us.
I really wish that could take place, that sending doctors from St. John's. To give just a small example, we need anesthetists since 19 years. We are not able to get anesthetist, and we just got one for last 2-3 months back, and he had to resign because the proper facilities are not there for maybe for his family, for his children and all that. So this development has to take side by side. Not only we are talking about only healthcare, but then the development in the rural areas should be overall development, the schools, the connectivity, the transport, everything. So this is one reason we are not able to get the specialists in the rural centers. So this idea would be very ideal.
The
and
Alumni
practical.
Association promises to be your voice to St. John's about this. I don't know if I can. Yeah. We're coming back to the panel. Yes, sister, we'll be your voice for that. We'll talk to STFI and together we will appeal for the same. Because I'm on the same side as you are. Right? We are not. Yeah. Yeah. So closing comments from anyone who feels motivated. Yeah.
It is with regard to Dr. Shailendra's intervention. I am convinced that doctors need to rest, prevent breakdown and burnout. But my conviction always was they need more quality family time. But you were suggesting on free days to have associations and meetings together. I was always convinced of more quality family time together, especially if your partner is not a doctor. What they go, or he's not a doctor. Either way.
Yeah. Dr. Ashley?
Both ways. Both ways.
He asked me, I said, I have a wife who's a doctor and 2 children, so yeah.
Yeah.
No, I agree with you, and I think associations do not just limit to doctors, but the families as well. And at least for me, I think when I come back to my department, it's almost like a family. And so I enjoy the association. I enjoy talking with my teachers, friends, teachers who have become friends. So I think that is what I was referring to. That I think if you are able to bond with the fraternity at the level where you're working, I think it makes a lot of sense. I just want to go back to that. I think the protection part which sister raised, I think there is a bigger issue there. It's not just limited to sister doctors, but in general, when doctors are working in the periphery, there is a problem of them getting beaten up. We've seen so many incidents where doctors are hit by enraged public, and that's a possibility. So obviously there are legal ways to address it. There is legal protection also provided. Local police can be involved. But I think one very important piece which Dr. Antony touched upon is how do we engage with communities and bring them as a part of the hospital and the facilities ecosystem. There are guidelines, right? NHM has published so many guidelines for that. There are Jan Arogya Samitis, there are Rogi Kalyan Samitis. But I think the requirement is a leader in that community who's going to really lead from the front to be a part of that
Correct.
system.
The solution is very local. The solution,
Yes, absolutely.
Mangalore is a group of doctors who face violence, who face all of this. So they formed a rapid action force. So one phone call, 25 land up. But that won't apply in any of the situations in the villages.
Correct.
But there you are probably going to be the only doctor who's around. Nobody else is going to. So strengthening local community.
Yeah.
There
and
are corporate
that also
hospitals.
boils down to what Dr. Ross was saying, that culture at the end of the day makes a difference. So all facility, when Sir was saying bottom-up approach, I think that's what it relates to. That how do you may have a common health and wellness center, right? That's perfectly fine. But at the local level, how do you customize services? How do you engage with the community? Makes all the difference. And a classic example that I talk about is McDonald's. When you go to McDonald's in the US, you don't get McDonald's paneer wrap. But in India, you get, right? And people in the US say, you get paneer in McDonald's? Yes, we do, because McDonald's has been able to identify that Indian population wants paneer in their burger and is able to cater to the needs. I think healthcare needs that kind of a revolutionary
Localization,
approach in terms of customization.
So I know that in some of the corporate hospitals here, we invite the politicians for the inauguration precisely to make sure that the gundas don't come to attack the hospital. And there are hospitals now which have professional bouncers who are actually dressed like bouncers, who stand there to protect. So the solution to this violence problem is not one, nor is it easy, and I think none of us will be able to give a one-shot suggestion. So you have to connect.
Shailendra, it happens in city of Bangalore, down Hosur Road. We get our front glasses routinely changed. So it's another thing. Now, I have just two little ending points on that. Arsenal is going to play in 15 minutes.
Give me the mic.
And I have to leave. So,
give me the mic.
I have just one word, maybe because of my grey hair and inability to stay quiet. I need one. You have to find another dimension to your life as a doctor. I play golf on Sundays. I paint. I read. I go for long walks. You must engage some other friends in some common thing that you enjoy. If you do all that, your mental health will automatically take care of it. And I'll strongly advise that that is an important thing. And we have been speaking about this hub and spoke wheel and supporting our sisters in the rural areas. I think we need to take it more than the Alumni Association. It has to be an institutional policy driven, that every sister that goes out to the periphery is identified, supported, and connected by a spoke to the main institution. And then when you have a problem, you will get immediate technical inputs or even physical inputs. If you want me to come there, I'll come and we'll do it. I go to Satya Sai Hospital. I go to Mauritius to set up surgical services, and we operate large numbers of patients. So there's no dearth of all this good work.
Yeah.
So please, on that note, I'll just wish me well that Arsenal will win today.
That's fine, sir. So I'd like to thank all of you for sitting through this session. It is really enriching for me to listen. We had no easy solutions, but at least I think we expanded on the problem. And we've sown seeds, I hope, wherein solutions can come in. I'd like to thank each of my panelists for being part of this and for all your varied inputs which have come from your life experience and your professional experience. Thank you very much. Thank you. Thank you very much, everyone. Can we have a picture with all the panelists on stage together, please? Father, come. Come closer. Come closer, sister.
The podium will... Anyway, I need the podium.
Take it on your phone. Take it on your phone. Yes. Just Jijo, she knows an action. Thank you. Thank you, Naveen. Thank you very much for coming along. Thank you, sir. Big difference. Thank you. Big difference. You made it.